Hi there, my highly valued and treasured viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa, and I am a clinical pharmacist by training and by profession. I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare sector workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services in your line of duty as you serve your employers. So I would like to urge you to kindly sit back and spare me part of your precious time as I impart a few tips. So welcome back to part 28 of our series. The first question reads, KHR, a 74-year-old white man, presents for a follow-up appointment post-discharge, which was 1 week ago, after admission due to a heart failure exacerbation. He has a history of coronary artery disease. He's had an MI. He has heart failure with a left ventricular ejection fraction of 33%, according to the echo that was done during the last admission. He's hypertensive and has dyslipidemia. He states that he has symptoms with activities of daily life, but not at rest. And he does experience shortness of breath and fatigue upon minimal exertion. These symptoms have worsened since his discharge a week ago. He currently takes 12.5 milligrams of Carvedilol orally twice daily, 10 milligrams of lisinopril once a day, 20 milligrams of furosemide once a day. He supplements potassium with 10 millimoles orally once a day, and he takes digoxin at a dose of 0.125 milligrams orally once a day. He also takes 10 milligrams of simvastatin at bedtime, and prophylactically he takes 81 milligrams of aspirin. His systolic blood pressure today is 130, diastolic 74. He has a pulse of 64, a respiratory rate of 24. He weighs 245 pounds, and upon discharge he weighed 238. So there's a slight increase. He could be retaining fluid. Selected physical exams, among others, are the JVD. It's enlarged. When you observe the neck, at the lung level, there are rails in bilateral lung fields. When you look at the limbs, it's 1 to 2 plus pitting edema bilaterally. And for the labs, the sodium is at 140, potassium at 4.5, BUN 18, serum creatinine 1.2, and when you check the digoxin levels, it's 0.8 nanograms per ml. So my question to you is, which of the drugs listed below would require a dose increase at the moment in order to improve KHR's condition? Would you adjust the digoxin, the Carvedilol, the lisinopril, or the furosemide dose? I'll give you 10 seconds to choose the correct answer. I would personally adjust the furosemide dose. Now the patient is slowly decompensating, as evidenced by 1 week of significant weight gain, worsening subjective symptoms, and physical findings consistent with fluid overload. He's in stage C or NYHA functional class 3, in my opinion. The most appropriate intervention now would be to increase the furosemide dose which is a loop diuretic, in order to improve his fluid status. There is retention of fluid. Increasing the carvedilol and the lisinopril doses, in my opinion, are both reasonable options to improve hemodynamics, since neither of them is at target heart failure doses. So there is still room to increase them, but this should be done after we have adjusted the furosemide dose. So I'll begin with increasing the furosemide dose first before tweaking the others. Let's move to the next question, which reads, a 53-year-old Caucasian woman, status post 1 year cadaveric renal transplant, secondary to uncontrolled type 2 diabetes mellitus, presents to the hospital with a past medical history of hyperlipidemia. She had NSTEMI 3 years ago, and she has GERD and has some neuropathic pain. Currently, she takes 81 milligrams of aspirin orally once a day, 20 milligrams of lisinopril once daily orally, 10 milligrams of amlodipine orally once a day, 50 milligrams of metoprolol twice daily orally, and she administers insulin Humalog 70/30 at a dose of 55 units in the morning and 30 units in the evening. Apart from that, she takes 40 milligrams of atorvastatin at bedtime and 10 milligrams of prednisone once daily. She's also on cyclosporin to prevent rejection of the organ at a dose of 700 milligrams twice daily. And because of the neuropathic pain, she is on gabapentin at a dose of 300 milligrams taken orally twice daily. She also takes calcium acetate at a dose of 1,334 milligrams with each meal. She also takes omeprazole at a dose of 20 milligrams orally once a day, and supplements with one multivite daily. Now, the immunosuppressive regimen has worked and has been overall well tolerated, apart from her cholesterol and her BP, which have worsened over time. The fasting labs today are including a potassium of 4.2, a creatinine of 1.2, the glucose at 142 milligrams per deciliter, the A1C is 7.2%, AST and ALT are 22 and 31 respectively, and the total cholesterol is 197, TG is 223, HDL is 32, LDL is 120, and the temperature is 98.9, the respiratory rate is 14 breaths per minute. She has a pulse of 65, systolic blood pressure of 134, diastolic 79. Now, the transplant specialist seeks your recommendation on further secondary prevention of cardiovascular disease. So my question to you is, assuming no other interventions can be made, which one of the ones listed below would offer the greatest ability of getting the LDL below 100 while also being the safest in this population? Remember, she's a transplant patient. Would it be increase atorvastatin dose to 80 milligrams at bedtime, what we call the high intensity statin therapy, or would you initiate ezetimibe 10 milligrams once a day, or would you switch atorvastatin to rosuvastatin high intensity 40 milligrams at bedtime, or would you initiate cholestyramine Questran 4 grams orally twice a day? I'll give you 10 seconds to choose the correct answer. So I would initiate ezetimibe at a dose of 10 milligrams once daily. Now, ezetimibe is an inhibitor of the Neumann-Pick C1-like peptide it's classified as a Neumann-Pick C1-like peptide inhibitor, whose use in renal transplantation appears to be safe. Also, it's effective and it doesn't result in significant changes in the calcineurin inhibitor levels, unlike some statins. Now, increasing the atorvastatin dose would only offer an additional 6%, that's too small, lowering of the LDL, and thus still not get the patient to their LDL cholesterol goal or target. Now, according to the KDOQI guidelines, they recommend a maximum dose of 40 milligrams of atorvastatin in patients taking cyclosporine, due to the fact that there is an 8-fold increase in the area under the curve of atorvastatin when the two are co-administered. That would increase chances of myopathy, rhabdomyolysis, and so on and so forth. Now, while switching to rosuvastatin, 40 milligrams would offer additional lipid lowering benefits over the 40 milligrams of atorvastatin. There is a dose limitation of 5 milligrams because when it's co-administered with the cyclosporine, there is a 7-fold increase in the area under the curve of rosuvastatin, and there would be high risks of rhabdomyolysis, myopathy, and all those other issues. And rhabdo would worsen the kidney function of a renal transplant patient, so I would not go there either. Now, initiating any bile acid binding resins would worsen this patient's TG, which are already above 200, thus further contributing to poor lipid management. So I would opt for ezetimibe and not the other three. Let's move to the next slide, which reads D.O.M. A 74-year-old man presents to the A&D with the supraventricular tachycardia. There is a past medical history there of atrial fibrillation, hypertension, and heart failure. He currently takes 100 milligrams of metoprolol tartrate twice daily, 0.25 milligrams of digoxin orally once a day, 5 milligrams of warfarin orally once a day. After therapy with adenosine, his underlying rhythm is identified as atrial fibrillation with ventricular response, but his ventricular rate rose back to 160 beats per minute. The clinical team would like to load Mr. D.O.M. on amiodarone 150 milligrams IV over 10 minutes now, because they are getting concerned about the 160 beats per minute. So my question to you is, which strategy listed below would be the most appropriate for D.O.M.'s condition? Would you opt to administer 150 milligrams of amiodarone IM, or would you increase the amiodarone to 300 milligrams IV and administer it over 10 minutes? Or is it true that when withdrawing the amiodarone from the vial, a filter needle would be required? Or is it true that when administering amiodarone, an inline filter is required? I'll give you 10 seconds to choose the correct answer. So D is the correct answer in my opinion. An inline filter has been recommended during administration of amiodarone to reduce the incidence of phlebitis. This is a result of hydrophobicity of amiodarone and the possibility of crystallization of the active ingredient. Remember, amiodarone should never be administered IM. Amiodarone doses of 300 are reserved for patients who do not have a pulse, i.e. those in pulseless VTAC or VFib, not in our particular case here. A filter needle isn't necessary when withdrawing amiodarone from the vial. I would just like to remind you that the diluent in the IV form of amiodarone is polysorbate 80, which is associated with hypotension if administered very rapidly, or if you administer it neat, undiluted. Now, each 100 milligrams of amiodarone, just for your information, contains approximately 3 milligrams of inorganic iodine. And amiodarone, if co-administered with simvastatin, which may occur in your line of duty, requires the simvastatin dose to be limited to a maximum of 20 milligrams at night. So those are small bits and pieces of information that you may need to know as you manage these cardiac patients who may have several drugs co-administered at any given time. Let's move to the next slide, which reads, which statement below concerning monitoring of digoxin therapy is the most accurate? Is it true that the risk of toxicity increases in the presence of hyperkalemia, hypermagnesemia, or hypercalcemia? Or is it true that signs of digoxin toxicity include nausea, vomiting, and visual changes? Or is it true that serum concentrations should be greater than 2 nanograms per ml for heart failure patients? Or is it true that renal function doesn't need to be monitored? I'll give you 2 seconds to choose the correct, 10 seconds to choose the correct answer. 2 would be rather short. It is true that signs of digoxin toxicity include nausea, vomiting, and vision changes. The common signs actually include nausea, vomiting, bradycardia. There can be CNS effects, notably blurred vision with disturbed color perception. And these patients may have halos around objects. Now, serum concentrations should be less than 1 nanogram per ml in general, and concentrations of 0.5 to 0.9 nanograms per ml are recommended to minimize the risks of adverse drug effects and to minimize chances of ventricular arrhythmia. So note that. Then the risk of toxicity increases in the presence of hypokalemia, not hyperkalemia, and hypomagnesemia, not hypermagnesemia, and of course hypercalcemia. So that makes option A wrong. Option D is also wrong because of what I've just explained. And then we know that digoxin is primarily cleared renally, and hence serum creatinine should be closely monitored to reduce the risk of adverse effects, because that will give you a picture of how well the kidneys are functioning. For most patients, the digoxin dose should be 0.125 milligrams per day. That should be adequate to achieve the desired serum concentrations. So yeah, we must monitor renal function. That makes option D wrong as well. So I would settle for B. Let's move to the next question. It reads, which of the statins listed below is not indicated in the reduction of TC and LDL cholesterol in patients with homozygous familial hypercholesterolemia, what we abbreviate as HOFH? I'll give you 10 seconds to choose whether it's Lovastatin, rosuvastatin, simvastatin, or atorvastatin. So A is the correct answer. Now, simvastatin, atorvastatin, and rosuvastatin are indicated to be used in patients with HoFH. Now, lovastatin and pravastatin are not indicated in this category of patients because such patients have defective LDL receptors basing on their genetical defects, and therefore those statins would not work well for them in lowering of the LDL cholesterol. Let's move to the next slide. Now, D.M is a 69-year-old Hispanic male who is referred to your clinic for angina management. He informs you he experiences 2 to 3 chest pain episodes daily, and they occur when he, in his own words, overworks himself. Now, he describes this pain as sharp or squeezing over his left chest without radiating, and he classifies it as a level 6 to 8 on a 1 to 10 scale, and he says it's relieved by rest. He has a past medical history of cardiovascular coronary artery disease. He had an MI a year ago. He's hypertensive. He has hyperlipidemia. He's obese with a BMI of 34. Some of his vitals include a systolic blood pressure of 145, diastolic 85. A heart rate was initially 88. Now, when you repeat the readings, the BP falls slightly to 143 systolic, 82 diastolic. The heart rate remains the same. He currently takes aspirin at a dose of 81 milligrams, atorvastatin at a dose of 20 milligrams at bedtime, 40 milligrams of lisinopril once a day, and he takes the isosorbide mononitrate SA 30 milligrams once daily. Now, assuming no contraindications to therapy exist in this particular case, based on the above information, which of the medications listed below would be the most appropriate to add onto his regimen to improve his angina management? Would it be Carvedilol at a dose of 6.25 milligrams twice a day? Would you opt for low-dose amlodipine at a dose of 2.5 milligrams once a day? Would you opt for spironolactone at a dose of 25 milligrams once a day? Or would you initiate the ARB Lovastatin at a dose of 25 milligrams orally once daily? I'll give you 10 seconds to choose the correct answer. I would settle for Carvedilol at a dose of 6.25 taken orally twice daily. Now, according to the ACC AHA chronic angina guidelines, all patients with coronary artery disease who have had an MI or an acute coronary syndrome or left ventricular dysfunction should be on a beta blocker indefinitely. Now, beta blocker therapy is missing in this patient's medication profile, and therefore Carvedilol would be the most appropriate choice. It would address both his BP issues because according to JNC 8, if I remember well, his goal should be below 140 over 90. And even the AHA's hypertension guidelines in patients with ischemic heart disease set the goal at below 130 over 80, and the heart rate goal. Now, the goal for such patients should be in the upper 50s to lower 60s as tolerated. Now, he isn't at goal yet. Now, by doing this, his myocardial oxygen demand will be decreased, and that will decrease the frequency of his angina as the parameters are improved and the dose is tweaked or titrated as tolerated. Now, in my opinion, amlodipine would be a good choice for management of both angina of angina. That is, it would improve both the blood pressure and the direct angina properties within the coronary arteries. But there's a caveat there. It would be considered second fiddle to the beta blocker according to guidelines. So I would only consider it after the beta blocker fails me. Now, Lovastatin, on the other hand, I would be reluctant to add it because the patient already has lisinopril, an ACE inhibitor. Lovastatin is an ARB. Well, it may have benefits in the management of hypertension, but addition of an ARB to an existing ACE inhibitor therapy hasn't been shown to be of benefit. I would rather go with one of the two, and then spironolactone would provide further BP lowering effects, but in this case it would be considered the third option behind Carvedilol and amlodipine. So our best bet would be Carvedilol, 6.25 milligrams orally twice daily. Let's move to the next question. You make a decision to administer doxazosin to a 66-year-old male patient who takes hydrochlorothiazide and metoprolol for the management of hypertension. What side effects is he likely to experience, especially with sudden movements or changes in position? Is he likely to experience edema to his lower extremities, reflex tachycardia, QT interval prolongation on his ECG, or orthostasis? I'll give you 10 seconds to choose the correct answer. So orthostasis is the correct answer. Now, also orthostasis is one of the classic side effects of doxazosin, which is also called Cardura, especially around the first dose when you're initiating therapy. It is even more of a risk in patients who are on diuretics, where the plasma volume may be slightly lower, and or in patients on beta blockers such as metoprolol, since they can't generate adequate increase in pulse to counterbalance the reduction in systemic vascular resistance that commonly occurs when we administer alpha blockers such as doxazosin. So let's move to the next question, which reads, in which of the following patients would you avoid reducing the starting dose of valsartan sacubitril, which is also called Entresto? Is it in patients with moderate hepatic impairment? Is it in patients with severe renal impairment? Is it in patients with moderate renal impairment? Or is it in patients not currently taking ACE inhibitors or ARBs, or previously taking low doses of the same? I'll give you 10 seconds to choose the correct answer. So it would be in patients with moderate renal impairment. Now, this fixed dose combination of valsartan sacubitril is indicated to reduce the risk of cardiovascular death and hospitalization for heart failure patients with chronic heart failure who belong to the New York Heart Association class 2 to 4 and with a reduced ejection fraction. Now, the starting dose is reduced to 24/26 twice daily for patients not currently taking ACE inhibitors or ARBs, or who are previously taking low doses of the agents, and even in patients with severe renal impairment and patients with moderate hepatic impairment. Now, no starting dose adjustments are required in mild to moderate renal impairment. So all those reasons explain why C is our best option. Let's move to the next question, which reads, which of the angiotensin receptor blockers below has an indication for treatment of heart failure? Is it Benica or Mesatan? Is it Valsartan? Is it Losartan or Telmisartan? I'll give you 10 seconds to choose the correct answer. So Valsartan it is. Valsartan has an indication for treatment of heart failure according to literature and guidelines out there. The other three, Losartan, Mesartan, and Telmisartan, do not have an indication for the management of heart failure. They are majorly used as antihypertensive drugs. Let's move to the next slide, which reads, PKJ, a 58-year-old Caucasian female, presents to the clinic with a past medical history of gout and hyperlipidemia. Her average BP on two separate readings is 137 systolic, 90 diastolic, with a heart rate of 70. During her last visit, the BP was 139 systolic, 92 diastolic. Some of the pertinent lab values include a sodium of 138, potassium of 4.5, serum creatinine of 1.4, a BUN of 14. So my question to you is, in which BP category does she belong according to the ACC/AHA hypertension guidelines? Is it elevated, normal, stage 2, or stage 1 hypertension? I'll give you 10 seconds to choose the correct answer. Falls in stage 2 hypertension. Now her diastolic blood pressure falls in category 2 hypertension, while her systolic blood pressure falls in category 1. Now when an individual has systolic and diastolic blood pressures falling in two categories, they should be designated to the higher category. Now the higher category in this place is 2 according to the diastolic blood pressure. So just for information, the normal blood pressure should be systolic below 130, diastolic below 80. Elevated blood pressures are considered when the systolic value falls between 120 and 129, and when the diastolic is below 80. Stage 1 patients have a systolic of between 130 and 139 and a diastolic of between 80 and 89, while stage 2 patients have a systolic that is equal to or exceeding 140 and a diastolic equal to or exceeding 90. So treatment of hypertension with antihypertensives should be initiated for adults with stage 1 hypertension who have an approximated or estimated 10-year ASCVD risk score of 10 or more, along with lifestyle modifications. Those are just for your information. Let's move to the next slide. It's patient EAD, a 70-year-old Hispanic male, reports to the clinic for continued dyslipidemia management. During his last appointment 42 days ago, his simvastatin dose was increased to 40 milligrams at bedtime. All other dosages were left unadjusted. Now, this gentleman says he's doing just fine without complaints and reports compliance with his medication regimen. He has a past medical history of coronary artery disease. He has had 2 MIs in the past. He's hypertensive, he has dyslipidemia, and is obese. Today he has a systolic blood pressure of 125, diastolic of 69 with a heart rate of 58. He weighs 246 pounds. He is currently taking 10 milligrams of amlodipine orally once a day, 25 milligrams of Carvedilol orally twice daily, 20 milligrams of lisinopril orally once a day, and He's on isosorbide mononitrate SA at a dose of 30 milligrams once daily. He also takes simvastatin 40 milligrams at bedtime. According to the labs, his chemistries are all within normal limits. His fasting lipid panel 42 days ago was a total cholesterol of 195, HDL of 26, LDL of 120, and TG of 248. Today, the total cholesterol has fallen slightly to 173. The HDL has risen to 28. The LDL has fallen to 104, and the TG has fallen to 205. So my question to you is, which of the recommendations below would be most appropriate for his management? Would you add gemfibrozil 600 milligrams twice daily to his current regimen? Or would you increase his simvastatin dose to 80 milligrams at bedtime? Or would you stop the simvastatin altogether and replace it with rosuvastatin at a dose of 20 milligrams at bedtime? Or would you maintain status quo? I'll give you 10 seconds to choose the correct answer. So I would opt to stop simvastatin and replace it with rosuvastatin 20 milligrams at bedtime. Due to an increased risk of muscle injury, the FDA recommends against the use of simvastatin at doses as high as 80 milligrams. Now, those limitations with medications that can cause increased simvastatin concentrations above 40 milligrams a day, such as the CYP3A4 inhibitors, need to be effected. And that includes amlodipine. It is recommended that when simvastatin is used concomitant with amlodipine, the maximum simvastatin dose shouldn't exceed 20 milligrams at bedtime. Therefore, in this patient, since further LDL lowering is still needed, switching to a more potent statin would be the best bet, and rosuvastatin happens to be that option. It would be our best bet in this particular case. Now, gemfibrozil is contraindicated with any dose of simvastatin, making the addition of gemfibrozil incorrect. Now, this patient already has clinically relevant atherosclerotic cardiovascular disease and should receive high-intensity statin therapy that would provide reductions in his LDL cholesterol by at least 50% according to guidelines out there, and rosuvastatin happens to meet these criteria. So I would settle for alternative C. I would stop simvastatin and replace it with rosuvastatin 20 milligrams at bedtime. Let's move to the next question, which reads, which of the antiplatelet agents listed below should not be co-administered with an aspirin dose exceeding 100 milligrams? Is it ticlopidine, is it ticagrelor, is it clopidogrel, or prasugrel? I'll give you 10 seconds to choose the correct answer. Ticagrelor it is. Now, in the Plato trial, PLATO, the use of ticagrelor with maintenance dose of aspirin above 100 milligrams decreased the effectiveness of ticagrelor. Therefore, after the loading dose of aspirin, use of ticagrelor with a maintenance dose of aspirin of 75 to a maximum of 100 milligrams daily is recommended. Do not exceed 100 milligrams of aspirin, otherwise you will undo the benefits of having ticagrelor there in that regimen. Let's move to the next question, which reads, D.L.W, a 69-year-old Hispanic male, presents to hospital for follow-up. Now, PMH, his past medical history includes coronary artery disease. He had an MI 5 years ago. He has heart failure with a left ventricular ejection fraction of 34%, and he's hypertensive. He notes that he has a dry, hacking, non-productive cough, which has lasted several weeks. He tells you initially he thought it was an allergic cough, but after taking over-the-counter antihistamines without improvement, he decided enough was enough, and he decided to report it today. He is currently taking 81 milligrams of aspirin once daily. He's on 12.5 milligrams of Carvedilol twice a day. He takes 0.125 milligrams of digoxin, 40 milligrams of furosemide once a day, and he also takes 20 milligrams of lisinopril once daily, and he supplements potassium at a dose of 20 milliequivalents once daily orally. Which of the interventions listed below would be the most appropriate for D.L.W to curb this cough now? Would you discontinue lisinopril and initiate hydralazine, co-formulated with the isosorbide dinitrate, taken thrice daily orally? Or would you discontinue lisinopril and initiate Lovastatin at a dose of 50 milligrams once a day? Or would you discontinue lisinopril and initiate amlodipine at a dose of 5 milligrams once daily? Or would you maintain status quo? I'll give you 10 seconds to choose the correct answer. So lisinopril is the culprit here. It's leading to accumulation of bradykinin, which triggers the dry cough in patients receiving ACE inhibitors. He appears to be experiencing an ACE inhibitor-induced cough, because we are told he has tried OTC antihistamines without successful elimination or improvement of his cough. Now, this patient has heart failure, where ACE inhibitors are considered a foundation medication for the reduction of morbidity and mortality. Now, when ACE inhibitors are not tolerated, they can be replaced first with an ARB, angiotensin receptor blocker, such as Lovastatin. And if the ARB isn't tolerated, then the initiation of hydralazine co-formulated with the isosorbide dinitrate, for example, could be considered as third-line approach. Now, amlodipine, in my opinion, would be considered reasonable as BP medication, but given the heart failure diagnosis, an ARB is superior to them all. I would consider it first line. So I would substitute lisinopril and replace it with Lovastatin. I would start at a dose of 50, and if need be, titrate upwards to the target. So B is our correct answer. TAO is a 56-year-old female patient who presents to the clinic as a walk-in. Systolic blood pressure is 183, diastolic 111, pretty high, and her heart rate is 95. You give her time to relax and repeat the readings. They have risen even further. Her current systolic is 185, diastolic is 113. The heart rate has also risen by 2 to 97. She is concerned that her blood pressure isn't lowering despite compliance with both her regimen and her lifestyle. She has a past medical history of hyperlipidemia. She has chronic heart disease, coronary heart disease, depression, anxiety. So my question to you is, which of the options listed below would be the most appropriate for the management of TAO's hypertension? Would you refer her to the A&D for the administration of IV hydralazine stat? Or would you admit her to the ICU for hypertensive emergency? Or would you intensify the current regimen, treat the anxiety if applicable, and arrange for close follow-up? Or would you stress compliance because this patient isn't experiencing hypertensive urgency? I'll give you 10 seconds to choose the correct answer. So I would opt to intensify the current regimen, to treat her anxiety if applicable, and to arrange for close follow-up. Remember, she's experiencing hypertensive urgency. The systolic is above 180 and the diastolic is above, for a patient to be classified to be in hypertensive urgency, the systolic should exceed 180 and or the diastolic should exceed 120. Now, a patient meets one of those. She meets the criteria based on her systolic blood pressure, and she's currently not experiencing any target organ damage. Now, the best plan for her is to intensify the oral antihypertensive drug therapy and to treat her anxiety and arrange for close follow-up. Now, admission to the ICU is only indicated in hypertensive emergency. She's not there yet with any new or worsening target organ damage. We don't see any evidence of that. In my opinion, she doesn't have target organ damage, and referral to the A&E would not be necessary. Additionally, IV hydralazine shouldn't be the first option for treating hypertensive emergency due to the fact that it is has unpredictable response and prolonged duration of action in most patients. It would not be our best choice. Now, this patient is compliant with her medications and her lifestyle from the brief interview we had on one-on-one when she walked in. Therefore, intensification of her current drug regimen is necessary to reach a BP goal of below 130 over 80 as per the ACC/AHA guidelines. Now, just for your information, examples of target organ damage used to identify hypertensive emergency include intracranial hemorrhage, acute ischemic stroke, acute MI, acute left ventricular failure, PE, aortic aneurysm, acute renal failure, and eclampsia in the pregnant ladies. Now, our patient doesn't have any of those. Yeah, that's just for your information. Let's move to the next slide, which reads SBW. A 42-year-old Caucasian male has an elective total knee replacement surgery scheduled sometime in the future. You establish he has been taking and tolerating prasugrel very well for ischemic coronary artery disease. This patient has a history of CAD and he's taken it for a total of 14 months, 1 year, 2 months. So my question to you is, how early would you withhold the prasugrel therapy prior to this elective surgery that is planned? Would it be 5 days prior, 1 day prior, 7 days prior, or 3 days prior to surgery? I'll give you 10 seconds to choose the correct answer. So prasugrel should be discontinued a week prior to surgical procedure, in part due to the fact that it irreversibly inhibits the P2Y12 component of the ADP receptor on the platelet surfaces. Now, the others, clopidogrel and ticagrelor, should be discontinued 5 days prior to surgical procedures, just for your information. Let's move to the next question. which reads A or M. A 60-year-old man has been in atrial fibrillation mode for the past 10 days, and he has a past medical history of hypertension and type 2 diabetes mellitus. And it tells you this is his first atrial fibrillation episode. Now, when you look at the echo that was done 30 days ago, it shows a normal ejection fraction of 60% and no left ventricular hypertrophy. And there's also no ventricular dysfunction. So the chief complaint, according to the patient, is occasional palpitations which occur mostly while he is active. He has a heart rate of 120, pretty high, and a blood pressure of systolic 140, diastolic 85. He is currently taking lisinopril 10 milligrams once daily for his hypertension and 5 milligrams of glipizide once daily for his type 2 diabetes mellitus. So my question to you is, what is his CHADS 2 score? Is it 0, 1, 2, or 3? I'll give you 10 seconds to quickly compute and tell me the correct answer. So the correct answer is 2, and I'll quickly tell you why. CHADS, CHADS 2, can be abbreviated at C for congestive heart failure, H for hypertension, A for age above 75 years old, D for diabetes mellitus, and S for stroke or transient ischemic attack. And patients can score between 0 and 6. Now, chronic heart failure, hypertension, age, and diabetes all score 1 point each. Now, stroke and transient ischemic attack are worth 2 points. So if you look at our patient, his scores are 2 because of the fact that he's diabetic, and I would just like to emphasize that this score helps identify a patient at risk of having a stroke with the chronic AFib of any type over the next 1 year. Our patient scores 2. Remember, he's diabetic and he has cardiac issues. So hypertensive is something on the echo. So let's move to the next question. SKM, a 66-year-old white male patient, is undergoing evaluation for stage C heart failure. His chief complaint is shortness of breath, fatigue with minimal daily activities, but is symptom-free when at rest. He reports 2 pillow orthopnea but denies PND or chest pain. When you do a physical exam, it's unremarkable, with an exception of stable 1+ pitting edema bilaterally. He has a past medical history of coronary artery disease. He has experienced an MI before. He has a heart failure with a left ventricular ejection fraction of 25%, pretty low. He is hypertensive and has dyslipidemia. Currently, he takes 10 milligrams of enalapril twice daily orally, 25 milligrams of Carvedilol orally twice a day, 0.125 milligrams of digoxin once daily. He supplements 10 milliequivalents of potassium once a day orally. He's also on torsemide, 40 milligrams once a day, and he takes 10 milligrams of raw Lovastatin at bedtime, together with 81 milligrams of aspirin once daily. Now today, when you look at his vitals, the systolic blood pressure is 124, diastolic 74, the heart rate is 62, and he weighs 185 pounds. Now, 28 days ago, the systolic was 122, the diastolic was 76, the heart rate was 60, and he weighed 187 pounds. The selected labs include sodium levels of 138, potassium 4.3, chloride 100, BUN 15, serum creatinine 1.1, and a glucose of 85. Now 28 days ago, the sodium was at 140, potassium was at 4.2, chloride was 98, BUN was 14, and serum creatinine was 1.1. His glucose was at 82, and when the digoxin levels were measured, then they were 1 nanogram per ml. So my question to you is, which pharmacologic intervention listed below would be the most appropriate to execute now? In the case of SKM, would you increase the digoxin to 0.25 milligrams orally once daily? Would you initiate fixed dose combination of isosorbide dinitrate and hydralazine at a dose of 20/37.5 milligrams thrice daily orally orally? Or would you initiate spironolactone at a dose of 25 milligrams orally once a day? Or would you increase the torsemide dose from 40 to 60 milligrams orally once a day? I'll give you 10 seconds to choose the correct answer. So I would opt to initiate spironolactone on top of his current regimen at a dose of 25 milligrams orally once daily. Now, all the options may appear reasonable to consider in specific situations. Now, in the RALES trial, RALES trial, which evaluated the use of spironolactone in severe heart failure patients with left ventricular ejection fractions of equal to or less than 35%, who belong to the New York Heart Association classes of 3 to 4, concomitantly treated with the ACE inhibitors, loop diuretics, and in most cases digoxin, there was observed a 30% reduction in mortality and a 35% reduction in hospitalizations and an improvement in overall New York Heart Association functional class. Now, this patient meets the RALES criteria and is actually designed to look exactly like the average baseline characteristics for this trial when you base on age, race, and blood pressure. The only difference between him and the RALES trial is the fact that he is on a beta blocker, which wasn't used in that trial, partly due to the fact that beta blocker therapy was emerging at the time of the trial. The use of isosorbide dinitrate co-formulated with hydralazine may be appropriate, but given that the data for this combination is stronger in the African American population or the black race in general, this wouldn't be the most appropriate therapy. It is unnecessary to increase the digoxin dose since the level is appropriate for heart failure patients, and increasing the torsemide dose doesn't appear necessary to me because there is no evidence of fluid retention. This patient looks euvolemic in my opinion. So I would not tamper with the furosemide dose at all. I would leave it as is. Let's move to the next question, which reads, when counseling a patient being initiated on clonidine or catapres for the management of hypertension, which of the following would be the most important counseling point to emphasize? Would you advise the patient to avoid abruptly stopping this medication due to a risk of rebound hypertension and tachycardia? Or would you advise the patient to call the doctor if they experience insomnia, since this is a common side effect? Or would you advise the patient to call their doctor if they should start developing constipation, since this is a common side effect? Or would you advise the patient to only take this medication as needed when they feel that their pulse and their BP are higher than normal? I'll give you 10 seconds to choose the correct answer. So I would settle for A. I would advise the patient to avoid abruptly stopping this medication due to a risk of rebound hypertension and tachycardia. Now, one of the greatest concerns with non-compliant patients is the risk for rebound hypertension and tachycardia, especially when they are on clonidine. And clonidine should never be taken on a PRN basis, or it should never be stopped abruptly. A failure to be compliant can result in significant blood pressure increase, even to a point of putting the patient at an increased risk for hypertensive urgency or emergency. Issues with clonidine are very serious, so you should advise them to try their very level best and comply. Never skip doses or take it on a as needed basis. So, my dear listeners, that brings us to the end of part 28 of our pharmacotherapy MCQ series. I highly appreciate the fact that you made time to view and to listen to this video. Now, if this video helped you or benefited you in any way, I would like to remind you to give it a thumbs up, to like it, to share it with your colleagues and your peers. And if you haven't done so, I would urge you to subscribe to my YouTube channel. I would like to promise you from the bottom of my heart that the best is yet to come. And I look forward to interacting with you in part 29 of this series. I sincerely thank you for always being there for me.